Okay, so this is going to look really similar to last time. So I appreciate the feedback that some of you provided about how you kind of want to see things go for this review session. So I've made a few changes, but I didn't get any emails ahead of time this week about any questions. So I will kind of go through in order of the lectures, but I do want to open it up first for questions, any logistical questions about the exam or any just questions not related to specific content that I can answer first. We're all good? All right, I will take silence as a yes. Feel free to use your emojis and everything too. Like I said, this is mainly for whatever is helpful for you guys. I have stuff prepared, but once we go through each lecture, feel free to jump in, ask questions, use the chat function, just interrupt me, whatever you want to do. So we'll start with the personality disorders then. Anybody have specific questions regarding that set of lectures?
Would it be all right if you kind of reviewed schizotypal? Only because it seemed the most similar to schizophrenia, especially with extremely odd and bizarre, and just kind of separating it a little bit.
Absolutely. Yeah, good question. And I will apologize. I was sick with the flu last week, so I think my voice is still a little nasally, so I do apologize, but good question. Let me get that pulled up for you quick. So I'll go through, because there's some specific things, especially related to the personality disorders that, there's a lot of them, right? And some of them are overlap. They look similar to, some of the psychotic disorders. So I'll give you some hints on kind of what to focus on for that. But in regards to schizotypal, so basically, this is just saying that the behavior that they present with is odd and bizarre. So think of it truly like a mild form of schizophrenia, but because it is a personality characteristic that's stable across time. And so we'll get into this a little bit more specifically when I go through kind of the criteria for some of these. But that just try and honestly think about it as schizophrenia. It's just in the context of a personality disorder, because those things are not going to wax and wane. That's going to be a pretty consistent presentation, whereas schizophrenia is cyclical, right? Like sometimes there'll be really bad delusions or hallucinations, and other time functioning's okay. With schizotypal, that's not the case. They're going to be exhibiting these things often. And like I said, I'll go into that one a little bit more specifically too when we go through that lecture, but good question. What else?
I was looking at the schizotypal that we're just talking about, and it says that the ideas of reference, and then it says excluding delusions of reference. And I was just kind of wondering if you could break that down for me a little bit.
Yeah, so that, let me just pull up. You're never going to need to know anything that specific for this. So because there are, a lot of different personality disorders, I do not expect you to memorize the criteria whatsoever. But I can explain that a little bit more. Just let me pull up. Let me see what I want you to know for that. Okay. So are you just asking kind of why that one specifically, why it doesn't include delusions of reference?
Yeah, and the ideas of reference, does that just mean it just doesn't escalate all the way to the delusions? Like it comes up with like there'll be an idea of reference, but it doesn't escalate to the delusion?
Yeah, that's exactly it. That's exactly what that means. Okay. Yeah. Yep.
Okay. Thank you.
And it's basically just, they're different from delusions of reference because they aren't like firmly fixed held beliefs, right? That's exactly what those are within psychotic disorders. but within this, it's not that. So that's how you could differentiate it between if somebody had maybe schizophrenia or, you know, like a personality disorder like that, is because it's not truly like that fixed, firm held belief that a delusion actually is.
Thank you.
Yeah, good question.
Oh, I have another question. Yeah, I'm sorry. I'm also sick, so I know that I'm very nasally.
Okay.
When connecting the goodness, now I can't. I believe the antisocial personality disorder with to women with the somatic disorder, were you saying that that's just how it's presented in women and this is how it's presented in men? Or like because I kind of like, I guess when I was listening, I was like picturing it as like if there were siblings that both had the same thing, like hereditary wise, the brother would have antisocial and the sister. As I was just trying to understand what you were meaning by the connection.
Yeah, good question. I'm trying to remember even what I said in that lecture. But that's basically what that is saying. You're pretty spot on with that. That's not anything you're going to need to know for this exam. So I wouldn't worry about it too much. I'm just checking my notes to see if I can give you a better answer for why I said that. Okay, so basically what I was getting at with that is that somatic symptom disorder, if we can remember back to that lecture, it's genetically linked to antisocial personality disorder. And so specifically through that impulsivity trait. And so I think what I was kind of getting at with, oh, let me see here. Oops. Yeah, and I think basically what I was just getting at with that is that there is that genetic contribution to that, and men are more likely to get that antisocial diagnosis, whereas women are going to be more likely to get that somatic symptom diagnosis. But again, you won't need to worry about that for the exam.
Okay, thank you. Yeah, it was just trying to connect them and how it was related was all. Thank you.
Yeah, just think of it as through impulsivity, essentially that inherited trait. That's the main point with that. So I have to reference my notes too, because I don't even remember what I say in these lectures a lot of the time. So other specific questions? Okay, well, feel free to jump in. I'm just going to go through a couple pointers specifically for this section that you should focus your studying on, but feel free to, like I said, interrupt. You can unmute yourself or you can just use the chat function, whatever's easiest for you. Okay. So obviously there's a lot of these personality disorders, right? So if you focus on what I underlined in those lectures, that will be the stuff that you should just know for each disorder. So I'm not going to expect you to remember every single thing. So like, for example, if you were trying to figure out what a paranoid personality disorder looks like, just know like the person doesn't trust, they're suspicious of others, even family members or friends, and there's no good reason. That's the extent that I'm looking for these. So don't feel like you need to memorize all of the criteria or have those ready outside of a couple specific ones. And I'll spend some more time on those ones. So things like borderline, because that is the most heavily researched personality disorder that exists. And so that one you're going to want to know a little bit more in detail. But for these other ones, just kind of know generally what do these look like, and some of them that, you know, maybe overlap or resemble one another, just kind of know how to differentiate it. So don't get too bogged down in those details. Okay, So one specific thing to know is the under-arousal hypothesis for antisocial personality disorder. So this is a really specific etiology for that, right? So this is just basically saying that individuals with ASPD start at a lower baseline level of arousal than most people. So that's why they feel this need to engage in very risky behavior in order to achieve optimal level of arousal. So that's all that is saying, but know what that is. That will be on the exam. So like I said, with borderline, because that is the most heavily researched, just know basically what it means, right? So like, know that it's typically a disturbance in their identity, right? They don't have a stable sense of self. They struggle with self-image. They engage in a lot of impulsive behavior. So things like substance use or casual sex or multiple partners without using protection, or significant mood instability. Like they have a really difficult time regulating emotions. So know generally kind of what those main characteristics look like and how it presents. And then what's the prognosis of this disorder? I mean, we kind of go into it a little bit more in depth compared to the other ones. So know what does it typically look like for these people? What's the expected outcome? Spend some time kind of reviewing that so you understand that. Everybody with me so far? Okay. And when these obviously are pointers of what to focus on. And by pointers, I mean, this will be on the exam one way or another. And so just know these things kind of more in depth compared to the other ones. Like, of course, you can reference your notes, but spend some time with these different areas. So another thing related to borderline, DBT. So that's dialectical behavior therapy. So that's the treatment that was specifically designed for borderline, though it's actually applied to a lot of different disorders. But just know generally what this treatment looks like. So essentially, because individuals with borderline have an inability to regulate their negative emotions, the goal is to basically get them to better accept and handle negative mood states without having to resort to like disruptive or dangerous behavior. So that's all at the most basic component that this treatment is. And so kind of just knowing generally what that looks like. And just knowing that main piece to focus on is the negative emotions, being able to kind of handle that mood state. Okay. So another thing, and we kind of talked about this a little bit earlier in regards to just differentiating when there's overlap between personality and psychotic disorders. And so a couple important things to keep in mind. So things like paranoid personality disorder, that doesn't involve delusion. So we know that's a personality disorder. That's how you can maybe differentiate that. So they think they're being harmed or that they're being deceived, and they will entertain the possibility that might not be true. So they're not actually delusional. So they can recognize like, yeah, this maybe isn't happening, but it still feels that way to me. So that means that they don't have a psychotic disorder. This is a personality disorder. Let's see. In addition, with paranoid personality disorder, oftentimes the person suspects that their sexual partner isn't being faithful, which again can sound like delusional disorder, jealous type, but it's only a suspicion, right? So they're not convinced their partner's cheating on them. If they were convinced, then it would truly be a delusional disorder. And then one of the biggest ways that you can differentiate that is just the stability of symptoms. So like I had mentioned before, schizophrenia is cyclical. So the delusions, the paranoia, these different symptoms kind of come and go. That's not the same thing for paranoid personality disorder specifically, because they're stable over time. So there isn't that ebb and flow that you would expect to see with the paranoia. That would just be constant. So those are the things to kind of look for specifically to be able to differentiate that. One thing to definitely pay attention to, know the difference between schizoid and avoidant, because they can kind of look similar. And so just knowing that avoidant occurs when people avoid social interactions and relationships, kind of similar to the schizoid personality, but it's not done for the same reason. So they both have overlap within that area. So whereas people with schizoid personality, they don't want relationships, they're indifferent to praise or criticism, they don't need it for that. People with avoidant are really hypersensitive to that criticism. So that makes them avoid the social interaction. So that's the biggest piece that you can tell between them, is that having that, being afraid of that criticism, that means you're going to be avoidant, right? Because you just don't want anything bad. Whereas schizoid, they really don't care. They're indifferent. They just don't want those relationships. So make sure you can tell those two apart. Similarly with avoidant personality, that also, I'll throw this out there, that also remembers an anxiety disorder. Does anybody remember or want to take a guess at which one that was? All right, I'll bail you out. It's social anxiety disorder. And so basically avoidant personality disorder is kind of conceptualized as a more severe version of a social phobia. So remember that in social anxiety disorder, people are highly anxious, specifically about like performance in social situations, which causes them to avoid them entirely. So that's where they're feeling that anxiety, and they still function really well in other areas of their life, including social interactions. So they still spend time with people socially. It's just that when they're anxious, they start engaging in a very specific behavior around others. So like speaking or eating in front of a group of people, that's when they would specifically avoid. Whereas avoidant personality disorder, all areas of life that include any social interactions, not just the ones where they feel like they might be negatively evaluated, they're going to avoid. So that's kind of the biggest piece that you can differentiate from those, but do know why those two look a lot alike. Okay. So those are my biggest tips for the personality disorder section. Not all of the personality disorders are even going to be on the exam. But like I said, definitely the ones that I just mentioned, know those ones a little bit more, and then know generally, what is narcissistic, what is obsessive compulsive, just generally know what those are.
So I have a question. So on the antisocial personality disorder, so since it affects the males the most, is the testosterone have anything to do with that? Like the levels of it?
Yeah, that is something that has been considered, but of course it's like a multifactorial process, right? There's going to be a lot of etiological factors there, but they are thinking that testosterone does play a part in that.
Okay.
Yeah, good catch. Other questions on personality disorders, things that you want clarified, questions, concerns? Okay. Everybody ready to move on to eating and feeding then? All right, specific questions for that before I go through my tips. All right, I will jump in, but again, feel free to interrupt. So, know generally, so these ones specifically, you're gonna want to know generally the criteria for them. So it doesn't need to be, memorized by any means, but you're gonna want to know because there are some overlap within these eating disorders. So being able to differentiate them, so know them pretty well. Don't spend as much time on like pica, rumination. That stuff is likely not even going to be on there. Focus most of your time on bulimia, anorexia, and binge eating. So those are the ones you're going to want to know. And so just generally speaking, no criteria for bulimia or BN, right? So just knowing that that's recurrent episodes of binge eating. So that's an objectively large amount of food in one sitting. Importantly, and this is extremely important for this disorder, is that they experience a loss of control. This will be on the exam one way or another. So no, that's just such an important criteria for this. So please, please, please know that one. In addition, they have inappropriate compensatory efforts. So I talked about this a little bit in lecture 2. This can look, like traditional things that we think of, like purging and vomiting, but it also can be things like excessively exercising and laxatives. And so know that the compensatory behaviors are maintained through negative reinforcement. So since they're more likely to keep occurring following the binge because they take the person's bad feelings away. So know that negative reinforcement piece and kind of the role that it plays within that. And then the person has, self-evaluation or self-worth that is unduly and largely influenced by their body weight and shape. So know exactly that last criterion, know what that means, right? And know which disorders that one impacts. So it impacts bulimia, and it also is seen in anorexia.
I have a quick question.
Yep.
Could you review the subtypes of anorexia with the binge eating purging type?
Yes.
Thank you.
Okay, so we'll just go through the anorexia criteria first, just to kind of start there, and then I'll break it down by subtype. But so anorexia restricts energy intake, right? And so this typically leads to significant low body weight. So this is the one disorder that you're going to see where people are extremely underweight, more so than the other two. So that's something that you can look for. Also, that intense fear of gaining weight or becoming fat. It's out of proportion to any other fear, right? This is all somebody can think about. This is their biggest concern in life. So they have to have that fear. And then disturbance in the way in which one's body weight or shape is experienced, right? So again, this undue influence on self-evaluation. We see it in anorexia and we see it in bulimia. And so with the subtypes, so restricting is no binge eating or purging in the last 3 months. So this is simply just, like counting calories, not allowing themselves to eat certain things, watching everything that they put into their body. And then whereas binge eating purging is during the last 3 months, they engage in some type of recurrent binge eating or purging patterns. And so although binges are seen in anorexia and bulimia, they're a little bit different, right? So in people with anorexia, binges are not excessively large like they are in bulimia. And so that's one thing to look for, is that yes, it can exist in both, but in anorexia, it's actually not an excessive binge. And so they're more likely to purge after almost every meal too. So if they are that subtype, they're going to purge after every meal, where people with BN will only purge probably like a few times a week on average. So it's not as consistent. And then, so if you're seeing really similar presentation between, if it's a vignette and it's talking about binge eating and purging, and you're like, well, I can't tell if this is AN or BN, the one thing you have to look for is weight. So low weight trumps everything, because that's the most serious symptom. So if someone is seriously underweight, they have anorexia, regardless of whether they're binging or purging. Does that break it down for you? Do you want more examples?
Yeah, no, that explained it well, especially adding that last part, saying when being faced with the binging and purging to separate the two of them, because that's what I was kind of struggling with. I'm guessing I didn't catch the part where it's significantly less food, because with the binge eating disorder, it's a lot of calories.
Yeah, and we'll talk about that one next, but we see a lot of the overlap between anorexia and bulimia, right? And some of those subtypes can look alike. And so that low weight is the one thing to look for, and just knowing that specifically for anorexia, it's not a large amount of food that they're eating, right? Because they're unable to even cognitively appraise what is objectively large. It's just so off kilter. And so that's why it might seem like it's a lot, but it truly isn't. Okay, we'll jump to binge eating. Okay, so again, recurrent episodes of binge eating as seen in bulimia. And so I think I went through an example, I'm not sure, where somebody just, had like an entire loaf of bread and just ate a ton of stuff. So that's exactly what you're going to be looking for, where it doesn't even seem like somebody could eat that much in one sitting, but they truly are. And so that, of course, is seen in both bulimia and binge eating. But one thing that you're going to want to look for binge eating is it's associated with things, with other symptoms specifically regarding that binge. So things like eating more rapidly, or like feeling uncomfortably full, or just eating a large amount of food when they're not even hungry. They're just eating. Eating alone, and then things like feeling of disgust and guilt. So typically, especially with binge eating disorder, you're going to see that guilt after that binge. But importantly, they don't engage in compensatory behavior. So they feel guilty, but they don't do anything about it. Whereas in bulimia, they might feel guilty, then they might, take a laxative, or they might purge. In binge eating, they're not going to do that. So their binge eating episodes must be associated with some of those other symptoms for this to be the diagnosis. Are we clear on how binge eating is differentiated from bulimia? Okay. All right. Okay, so let's see. So another thing, and this is gonna be a question on the exam, is know which eating disorder is considered a culture-bound syndrome. Does anybody know which one?
Anorexia?
Anorexia.
Anybody else have a guess? It's close. You would think that would be the one, right? You would think it would be anorexia, but it's actually bulimia. So basically, it's considered a culture-bound syndrome, meaning that it's not found everywhere in the world. So anorexia is actually found in most cultures, but bulimia isn't. So bulimia is typically only found in cultures that have exposure to Western media and ideals, and also have access to plentiful food and private places to purge, right? I mean, that's not a luxury that a lot of cultures have. And so that's why this one is specifically a culture-bound syndrome. So you would think anorexia would be just because we live in this Western ideal, right? But that private place to purge and access to food, that's such a huge thing. I mean, there's a lot of places where they can't actually have this disorder because they don't have that kind of access to food. So know that one. Does that make sense to everybody? Okay. All right, let's see. So generally, we've covered this already with the criteria, know what disorders involve purging. So again, that's bulimia and anorexia, and purging is not a characteristic of binge eating. So make sure you know that. Another thing, and we'll talk about this more when we get to the developmental lecture, but stimulant medications effective for ADHD, right? And I spend a lot of time talking about that, but I mention it within this lecture too. So specifically for binge eating disorder. So you don't need to know the medication, but it is Vyvanse. And so that actually has been approved for binge eating disorder. So it's been found to help kind of reduce episodes of binge eating. And so just make sure you know that, yeah, we can see this can be something that's prescribed for both ADHD and binge eating disorder. Okay. All right, and then like I had mentioned before too, with loss of control. So we see binge eating in all of these disorders, right? It can be a subtype of anorexia, it can be in bulimia, it could actually be binge eating disorder. Know that loss of control piece, especially to differentiate between BN and binge eating disorder. For bulimia, you need to have that loss of control. Okay, so that looks like everything I had for the eating and feeding. Anybody have any other questions or want clarification on anything? No, we're good. Okay. And those areas that I told you to focus on, those are the ones to truly focus on. They might be on there more than once, be able to differentiate the overlap. And like I said, worry less about like Pika and that kind of thing. I'm less interested in those. I want you to truly know these three big ones. Okay, everybody ready for sexual disorders then? Any questions to kick us off that anybody has?
I guess, are there going to be like main ones that we focus on, or is it going to be touched? Each one will be touched on a little bit.
So you won't be expected to know all of them. I'll go through some of the bigger ones that I do want you to spend more time on, but it's similar to personality disorders. Generally know what they mean. I mean, I know there's a lot of criteria with this, but just kind of be able to, generally know, like so for example, this is kind of what I would expect you, like to the level I would expect you to know. So if we think of like fetishistic disorder, that is basically just that urge or behavior, sexual arousal, right, from non-living objects or non-body parts. That's all you need to know. So just knowing generally kind of what that disorder entails. It's all recurrent sexual arousal or urges, right? It just depends on what specifically it's in regards to. Other questions? There's a lot of them. There's a lot of sexual dysfunctions too. Again, not all of them are going to be on there. I'll give you some hints for ones to focus on, but just make sure you have those notes readily available if you can't memorize them. Okay, so let's see. Let's start with, so do know gender dysphoria. Kind of generally just, a reminder, it's incongruence between one's experienced gender or expressed gender and their assigned gender. So just at its most basic level, know what that is. And then know generally the difference between child and adult outcomes. I spend some time talking about specifically for adults, options that if they're diagnosed with this, options that they pursue. But less so in children, right? So we have to see a lot more symptoms in children to actually give that diagnosis. But I do spend some time talking about what typically happens to children that display some of these symptoms. So know generally what that means.
When you were talking about the treatment in children with gender dysphoria, I was a bit surprised that it was to discourage the behavior and to reinforce what, I guess maybe it was a little confusing, I guess, talking about the treatment in children and why it's so different than adults and adolescents.
Yeah, and you're not going to be asked to know treatment for children specifically because we don't have good treatment. So that's why we don't give this diagnosis. I have never really heard of any child getting this diagnosis. We typically try and wait until they are an adult. And if they're still experiencing some of these symptoms, then there's these different options that we can do for them. But sometimes it's hard to differentiate between just kind of exploration or trying to figure out sexual identity. There's time that, kids need. So we don't have good treatments. And so that's probably why it was confusing, is because we really don't know how to treat that. But generally speaking, if we see some of these symptoms in childhood, typically they grow out of them. And so that's just one thing to kind of look for. I know that's a
thanks.
really
Yeah,
bad answer.
No, it's actually a lot more positive because I was just surprised that it was just so different and it was just confusing. But it sounds like a lot more just letting the child do their thing and address it later.
Yeah. Yeah. And I mean, you've got to give them space to figure that out too, right? I mean, we can't tell, a lot of times we see parents or authority figures try to push a gender on a child. And so our kind of approach just within the psychology field is to let them figure it out and express it themselves. And if there is incongruence with that and difficulty with that, then we can treat those symptoms. But there's not always distress associated with that. Okay. Good question though. Okay, so one disorder to spend some time on is voyeuristic disorder. Kind of just know the details regarding this. Specifically criteria related to age and distress with this disorder. So just a reminder, this is kind of that sexual arousal from observing an unsuspecting person who's either naked or disrobing or engaging in sexual activity. And so know specifically for that kind of what the age, why we recommend 18 for that one, and know generally speaking, if this person has to experience distress, if others have to experience distress, this one is unique compared to all the other sexual disorders. So spend some time with that one. Okay. Another one, fetish disorder. I kind of use that as an example again, but spend some time knowing that one. That one's for sure going to be on here because we do kind of see this one more so than some of the other ones. So generally knowing, that they're attracted or aroused by non-living objects and kind of focusing, making sure that you recognize, especially with this disorder, that it has to be like non-genital body parts too. So like this is exactly, I think I gave an example in lecture where, it could be like feet or shoes, something like that. So it can be a body part, but it just can't be any genital area. Okay. So for pedophilia, the biggest thing to know with this one is just know the difference between situational and preference. So again, a reminder, situational, somebody's primarily interested in relationships with adults, but during a stressful time or if they're under a lot of pressure, they might have impulses towards being attracted to children. And so they engage in this event, and extremely important, they feel distress afterwards. And so they feel really guilty, they feel really bad about it. Of course, that doesn't make it okay, but that is very different than preference, right? So that's somebody who has a clear sexual preference for children and they see nothing wrong with their behavior. So they're not going to experience that guilt. So just know, generally speaking, kind of the difference between those two. Okay. So in regards to sexual dysfunctions, so again, you don't have to worry so much about all the different categories. I know I broke it down by like desire, arousal, all of that. Don't spend a ton of time on that. These are kind of the areas that I want you to focus on. So one thing in particular is etiology. So know kind of how these are derived. And so on its very basic, things like medical conditions, right? So both men and women can have sexual problems. Think like diabetes, kidney disease, things like that can interfere with that. So generally, just very generally, medical conditions. Age is a huge one, right? So this is associated with declining levels of testosterone and estrogen. So this is why sexual dysfunctions are not diagnosed in children or emerging adults. Age has to be something that's considered. So another thing could be medications. So that can impact blood flow. Importantly, we talk about SSRIs a lot in this class, and a side effect of SSRIs can actually decrease sexual arousal or sex drive. So just generally, you don't have to know the specific med for that, but just know that meds can impact that. Things like chronic substance use, different psychological disorders like depression and anxiety, and then just kind of having relationship problems, right? Like if somebody is struggling in their relationship, that might cause some type of sexual dysfunction to occur. So I know that seems like a lot of etiology there, but on its most basic level, just kind of know how somebody might develop some type of sexual dysfunction. And these are pretty straightforward. I mean, you would kind of expect them. So then also no treatment. So again, medications can be used. You know, an example I gave with this was specifically Viagra for men. And I don't know if anybody else picked this up, but there's basically no medication for women that's comparable to men. And so that would only be seen for men who have sexual dysfunction. So medications would be used for that specifically. And again, like penile injections or implants, again, men have typically more options than women, unfortunately, but that's one thing that you could pay attention to. And then I went through some of those general examples. So you don't need to know them in a lot of detail, but know like the directed masturbation exercises, sensate focus, that pause and squeeze technique. Know what those are. And I mean, I don't spend a ton of time on them in lecture. And so that's only the extent that I expect you to know it. Everybody with me so far? You know, I'm throwing a lot at you, but let me know if I need to slow down. Okay. And again, feel free to jump in if you have questions or concerns on anything. So one sexual dysfunction, let's see. Oh, so this is an example of kind of similar to the paraphilias, like what I would expect you to know. So like know for like erectile disorder criteria for that, that would just literally mean difficulty obtaining an erection or maintaining or completing sexual activity, right? So and this causes significant distress. So that's all I would expect you to know. But then if you were gonna, you know, presented with a vignette and you kind of see that, I would expect you to know, well, if they can't maintain or if they can't obtain one, it's likely erectile disorder criteria, right? But if it's, you know, delayed in ejaculation or they can ejaculate, then know that that would be delayed ejaculation disorder. So those will be very surface level questions and very straightforward. Okay, and then another thing too, with transvestic disorder, know what autogenophilia is. You know, we spent some time talking about that, but basically kind of focus on the idea of exhibiting female physiological functions. So like lactation, menstruation, and then the man typically engages in like stereotypical feminine behavior, or they want to have the anatomy of a woman. So know what that term means. And then how that kind of relates to transvestic disorder. Okay, that is everything I have for sexual disorders. I'm going to come back to it at the very end to give you a couple more pointers on that, but that's generally what you should know for that. Any questions? Okay, we will move on then to the developmental, disruptive, and impulse control disorders. So for this one thing, spend some time knowing and know kind of what it entails is cohesive family model therapy. And so this was a very specific treatment that I talked about, and this is specifically for reducing symptoms of ODD and especially conduct disorder, because we see a lot of overlap between those two. But just know that it's for those two disorders. It can be really difficult to implement because parents need to be willing to engage in treatments. And that's a necessary component. So if they're not willing to be a part of it, then you can't do this therapy. And so basically, it's thought that parents of kids with conduct disorder or ODD may be lacking in some parenting skills and maybe behave in inconsistent ways. And so essentially they start to reinforce this inappropriate negative behavior. And so the kid starts to think, well, this is okay, I'm going to keep doing this. And so the focus of the treatment is just restoring functional patterns of behavior between the parent and child at its most basic level. And so just kind of generally know what that means. So with with tic disorders, kind of be able to differentiate them. So know that, specifically for Tourette's, this is diagnosed when someone has both motor tics and verbal tics. And so, this could be somebody who engages in like shoulder shrugging or mouth twitching, but they have to have both motor tics and verbal tics. So you have to see it both for Tourette's. And so just a reminder, it has to have occurred for over a year and start prior to age 18. But again, that criteria is not going to be directly assessed on this exam. But just know that's what Tourette's is. Know that obviously persistent motor tic, they have to have only motor tic, persistent vocals, only vocal, and then provisional. So they can, this one can resemble Tourette's, so they can have any combination of tics. So they can have both, maybe vocal or motor, or they can only have one type. The main difference is that the time duration for this one. So regardless of type, this one must last for less than a year. And so that's the biggest difference for provisional, is that time duration piece. Questions on Tourette's or tic disorders? Okay, so no intellectual disability. So I know, like, going through a lot of these, a lot of them have a ton of criteria, right? So what I want you to just focus on, so like specifically for intellectual disability, the criteria that I'd expect you to know for this is just generally deficits in intellectual functions, right? So this is confirmed by that clinical assessment piece or standardized testing. And so that has to be done. And then they have deficits in adaptive functioning. So I went through a whole host of options for this one, but it can be difficulty in personal care, interpersonal skills, safety, just some life area has to be impacted by that. And then the last piece, all you need to know is that it occurs during the developmental period. It has to start early. This is kind of when I went through, the importance of that criterion, because this could resemble somebody that maybe developed dementia or something later in life. And so that's why that criteria is so important. But that's all I would expect you to know. So there's probably going to be a question that says, what is not a criteria for intellectual disability? So know those three areas that I just said. Okay, so enuresis and encopresis. So generally just know the difference. Enuresis, just as a reminder, is repeated urination. This can be intentional or unintentional, and encopresis is poop, right? And so just being able to remember the difference between the two. But one thing you should know is treatment specifically for enuresis. So treatment for encopresis is essentially just empty bowels and institute regular bowel movements, right? So there's less involved with that. Whereas enuresis, basically the common presentation with this is the kid doesn't learn how to inhibit bladder emptying overnight. And so that's what's typically targeted. And so this is through classical conditioning procedures. So know that classical conditioning is involved with this. And so I went through that example, basically that the child needs to learn how to wake up when they have to go to the bathroom so that they don't just automatically pee in their sleep. And so medications can be used, but typically classical conditioning procedures are going to be implemented first. And so this isn't something that you have to know outside of that detail, but know how classical conditioning is involved in that. Okay. So back to some criteria, there was a ton of information on autism, And so there will be a couple different questions related to autism on this exam. But again, for criteria purposes, no deficits in nonverbal communication, deficits in developing and maintaining relationships, and then that restricted and repetitive behaviors and interests. Does anybody know what isn't a necessary criteria that sometimes is presented? Language. So I go through a whole thing talking about can be diagnosed with a language specifier, without. Just know that's not a necessary criterion for that. So make sure you kind of understand why that's the case. With autism, applied behavioral analysis is gold standard treatment. So know generally what that is. And by generally, I mean know that operant conditioning principles are used, right? So I go through kind of a whole example that discusses discrimination training and shaping, but just know kind of generally why operant conditioning is used. And I went through that very detailed example. So if you want to spend some time just going through that, you're not expected to, like, it's not going to be a short answer question, but just know why operant conditioning is seen in this one. Okay, and then last, generally just know the difference between conduct disorder and ODD. So just a reminder, conduct disorder can be thought of as kind of like that kid version of antisocial personality disorder. And so it involves kind of that violation of rights of others and kind of rules of society. And so this is where, they have aggression to people and animals, they destroy property, theft, they break rules. So kind of these big, big things. And just know that if it's over the age of 18, then you'd have to rule out antisocial personality disorder, because a lot of times they can look very similar. So you have to make sure that's why that criterion is so specific, is because it's kind of like the kid version of it. So that's exactly why that's in there. Importantly, with this disorder, it doesn't include distress, right? So kids with conduct disorder might not actually be impaired by this, and that's why it resembles antisocial personality disorder as well. But age is important to take into account here. So just know kind of generally the reason why. And then just very, briefly, oppositional defiant disorder. So ODD, diagnosing kids who, they're really irritable, they're angry, argumentative, defiant. And then this is associated with distress in either their individual functioning or it impacts others. And so it's kind of like a less severe version of conduct disorder. Questions on those?
There's quite a bit on ADHD. Are there some main points that we should focus on with that one?
Yep, generally know how you would know if it's inattentive or hyperactive, impulsive, or combined. And so I go through kind of that example. And so just know, generally speaking, how you would make that determination. And medication, right? So typically stimulants are first line approaches. And so kind of just know that piece with it. There isn't going to be a ton of questions on ADHD, but it's likely going to be things like, this person is experiencing 4 of these symptoms. What likely would you diagnose them with? So just be able to differentiate those subtypes. Does everybody feel pretty confident in those? Yeah, they're pretty straightforward. It's either, okay. But yeah, good question. Other questions on this lecture? Because I know we covered a ton of information in it. Okay, so last but not least, for the short answer portion of the exam, spend some time with the treatment and kind of etiology for paraphilias. And so by that, I mean, you're going to be asked to kind of know etiological factors for paraphilias generally, like not specific ones. So I'll likely give you an example of a paraphilia, and then you can kind of talk about it in that regard. But the etiology is the same. And so basically they're classically conditioned, right? So it typically begins in adolescence And this is a time when, especially for boys, right, sex drive is really high. And so they pair and make these associations, sexual associations. And so I go through an example of kind of a shoe fetish in that lecture. That's the extent that I'd want you to know. So just be able to kind of classically, or talk about classical conditioning procedures within the development of that specific disorder. And then be able to differentiate and know generally the treatment for paraphilias. So aversion therapy. And so this is basically when somebody's asked to masturbate to that paraphilic object, right? And then receive some punishment while doing so. So that can be things like being shocked or kind of exposed to like a really bad smell. And so that stimulus becomes classically conditioned with something bad rather than sexual pleasure, right? We're breaking that association. And so you're pairing that with like feeling sick or these bad smells. And so eventually that sexual paraphilic stimulus is associated with feeling sick. So just know generally like what aversion therapy kind of looks like. Everybody with me so far? Okay. Orgasmic reconditioning. Generally, this is where like a man would be instructed to masturbate to his paraphilic stimulus, right? And then right before he's about to orgasm, that stimulus would be replaced by a more appropriate stimulus. So I think I gave the example in lecture, like a picture of the man's wife. And so basically with this is we're trying to pair that appropriate sexual stimulus with masturbation so that they learn that's an appropriate way to masturbate rather than to this inanimate object or whatever the case may be. It can be as simple as that. So don't overthink these, just kind of keep it at its basic. And then last, covert sensitization. So just a reminder what this is, a man is instructed to kind of imagine engaging in whatever paraphilic act he has. And so an example of this could be like exposing his genitals to women. And so then he would be asked, excuse me, to like imagine in detail negative consequences. So think like doing this in front of your family and friends, the shame and embarrassment associated with that. So making them really think of those negative consequences and then imagine those negative emotions. That's a huge piece. So feelings like shame, feelings like guilt, we need to spend time with those negative emotions in treatment. So that's one thing that don't gloss over. Make sure that it's not only negative consequences, but negative emotions. And so they need to emotionally experience those repercussions. And so that should hopefully deter them from wanting to do that behavior in the future. So those are the three big treatments. So those are going to be ones that you should be able to talk about in an example. Questions on those? So my biggest piece of advice because I know, some of you had mentioned being worried about all of the different options. So know those treatments, know the etiology, because they're going to be the same for no matter the paraphilia that I give you. But if I was going to spend some time studying certain ones, I would probably focus on fetish, transvestic, pedophilia, and exhibitionistic. That's what I would spend my time on. Okay, so that's everything I have. Questions, concerns, thoughts? Anybody need any clarification?
When again does the test open up?
So Monday. So you'll have all week. So I recognize that it's a holiday weekend. It'll open right away, midnight, Monday morning, and then go through Sunday. So you'll still have the full week.
Okay. Yeah, grandkid is coming over, so woo.
Well, and which is why I'm not giving a lecture next week either. So just take the exam and then, spend the rest of the time, enjoying the holiday and not worry too much. We only have one more lecture after this. So okay. Yeah, hopefully that will make it a little bit easier too. You don't have to learn new material at the same time.
Right, thank you.
Other questions? It's gonna be the same exact thing with honor lock. You'll, still have 75 minutes. You'll still have notes that you can use, the handwritten notes. Obviously take it whenever you feel comfortable doing it, but I wanted to get this review session done early so that you had appropriate amount of time if you wanted to take it before the holiday. Try not to wait till the last minute in case things come up. I know things happen, but that's why I give you an entire week to take it. So I definitely encourage you to take it early and then just not think about things for a bit. Anything else anybody has? Okay. So I had less specific questions. I do appreciate the participation today, but generally, was this helpful? Were there things that you didn't like?
I think you hit points that people did ask and the stuff to study. I mean, you were very specific about it, and I think that's good.
Yeah, it was really good. I like the distinguishing between other disorders because that can get really confusing, and separating and teasing them apart, especially with the personality disorders. It even sounds like the professionals have troubles with it too. So,
oh yeah, which is why, we never do things without a DSM. We always consult. So I wouldn't expect you guys to memorize and know these things. And so that's why I spend the time on some of these things where we see confusion, right? And so that's the stuff that I want you to pay attention to. Okay. Well, I do appreciate, everybody spending their Thursday night. I know it's not the most enjoyable thing. Feel free to email me if you have more specific questions or things that I can help with for this exam. So just a reminder too, so the final exam is going to look a little bit different. That's going to be more vignettes. It's going to have, it's multiple choice. There won't be, I don't think there's a short answer portion on that, but I'll double check and just let the whole class know. But practice those, the what's the disorder activity. That's essentially what that's going to look like. But I'll give you more specifics for that because I do recognize that we covered a lot of disorders. And so I'll give you some specific guidelines for that as well.
The paper that we're doing too, like, if we're looking at those videos and stuff, is there some place that like UW has where you can go in and look at those movies, or do you just have to? I noticed that a lot of them you have to pay for if I have to rent them or whatever.
I can do some checking. So I know there's some like Netflix, Hulu. So a lot of times that's why those are readily available. But if you don't have access to those, then let me know and I can potentially get you access to a specific movie if you need it.
Okay.
Yeah. So if anybody else is having problems, let me know. But I know like for sure there's a handful that's on Netflix. There's a couple on Hulu. So just keep me posted if you can't find these movies.
I think it's what Mr. Jones is the one that I was looking at, the one
Okay.
that deals with the bipolar.
Okay. I'll make a note to see if I can help you with that one.
Okay. Thank you.
Yes. Let me see. I had one question. Yeah, you can use notes on the final too. I'm fine with that. You're going to have longer on the final. It at minimum 120 minutes, likely going to be 150. You're going to have plenty of time. But this is basically just going to be like you're going to read about a presentation and just kind of know generally what the disorder is. And so you won't have to focus on all of the criterion. It's more kind of what is this, an anxiety disorder? Is this a mood disorder? So like I said, after we get done with this third exam, I'll give more specific guidelines for that, but notes will be allowed on it.
And then, so for that, then when you're going over all of those disorders, are you going to go back through like when on our lectures, give the answers to those disorders on the vignettes that we had?
I'm not going to make the answers available because people have kind of been doing them throughout. And so test yourself. This is a way to actually practice. And so that's why I don't give those answers. And so if you want, just email me your answers and I'll let you know if they're correct or not. So that's literally what the exam is going to be. And so just email me. And if I don't get back to you, email me again because I'm flooded with emails a lot of times. So I apologize if I don't get back to you right away, but just email me your answers and I'm happy to help with
Okay, thank you.
Yeah, it'll be more, kind of my advice will be more, here's what you should focus on when studying, because I do recognize there's a lot for the different criterion. So I'll give you more specific examples for that.
Okay,
And just a reminder too about that paper, if you want feedback on a draft, try get it submitted by Sunday. I understand things come up, so if you need additional time, but just know that will be less time for you to work on it because I'll need a week to go through everybody. So if you do submit it late, just let me know and I'm happy to work with you on that, but you'll have less time to turn in that final draft then. All right, any other questions? Okay, just let me know if things come up, and thanks for coming.
thank
Thank
you.
you.
Bye, everybody.